There is a class of molecules that your body already produces, that your cells already respond to, that regulate tissue repair, immune function, fat metabolism, muscle growth, skin regeneration, and even the rate at which your brain ages. These molecules are called peptides. And over the past 2 decades, a parallel scientific universe has developed around synthesizing them, injecting them, and using them to push human physiology in ways that would have seemed like science fiction 30 years ago. Some of these peptides have extraordinary animal data behind them. A few have meaningful human data. Some have almost none. And the gap between those categories is not just scientifically important, it is the difference between a potentially useful intervention and a genuinely dangerous gamble. Today, we are going to walk through all of it with as much precision as the current evidence allows. Welcome to the Huberman Lab podcast, where we discuss science and science-based tools for everyday life. I am Andrew Huberman, and I am a professor of neurobiology and ophthalmology at Stanford School of Medicine. Today's episode covers one of the most requested topics I have received since starting this podcast, and one of the topics I have been most cautious about covering precisely because of how complex and nuanced it is. We are going to talk about peptides, their history, their mechanisms of action, their uses, the sourcing landscape, and critically, their safety profile. We are going to cover BPC-157, which is perhaps the most widely used peptide in the biohacking and sports medicine communities. GHK-Cu, a copper peptide with a remarkable range of effects on tissue repair and gene expression. Pinealon and Epithalon, 2 peptides with intriguing data related to aging, brain function, and longevity. The GLP-1 receptor agonists, including semaglutide and the newer retatrutide, which have become arguably the most medically significant drug class of the past decade, melanotan and its derivatives, and the growth hormone secretagogues and releasing peptides, which represent an entire category of compounds with significant performance and longevity implications. I also want to be very clear about what today's episode is and is not. This is an educational episode about the science of these compounds as it currently stands. It is not medical advice. It is not an endorsement of using any of these compounds. Many of them are not approved by the FDA for human use. Some are research chemicals with no approved human applications whatsoever. Others are approved medications used off-label. The distinction matters enormously, and we are going to be precise about those distinctions throughout. If you are interested in any of these compounds, the appropriate starting point is a conversation with a qualified physician. Timestamps are in the description below, so feel free to navigate to the specific compounds that are most relevant to you. Before we get into the science, I want to briefly mention our sponsors. Sponsor mention AG1. I take AG1 every morning as a foundational nutritional base. It covers vitamins, minerals, adaptogens, and probiotics in a single convenient serving. Go to drinkag1.com/Huberman to get a free 1-year supply of vitamin D 3 plus K2 with your first order. Sponsor mention 8 Sleep. Recovery is everything when we are talking about tissue repair and the kind of physiological optimization that peptides are often used to support. 8 Sleep's pod mattress cover automatically adjusts temperature throughout the night to optimize sleep quality and recovery. Visit 8sleep.com/Huberman to learn more. Sponsor mention LMNT. Electrolyte balance affects every cellular process we are going to discuss today. LMNT provides the sodium, potassium, and magnesium your cells need without any sugar. Go to drinklmnt.com/Huberman for a free sample pack with any order. Without further ado, let's dive in. Let me begin with the foundational science of what peptides actually are, because I think this is something that is genuinely misunderstood in popular discourse, and getting this right will help you evaluate everything that follows with a much clearer lens. A peptide is a short chain of amino acids, and what I mean by that is this. Your body is built out of proteins. Proteins are large, complex molecules made of amino acids linked together. The average protein contains hundreds to thousands of amino acids. A peptide, by contrast, is a shorter chain, typically defined as fewer than 50 amino acids, though the precise cutoff is somewhat arbitrary, and the terms peptide and small protein are sometimes used interchangeably for chains in the 30 to 50 amino acid range. What makes peptides biologically significant is that they are not merely structural building blocks the way longer proteins often are. They are signaling molecules. They carry information. They bind to specific receptors on cell surfaces or enter cells and modulate gene expression, enzyme activity, and cellular behavior. Your body produces hundreds of endogenous peptides. And what I mean by endogenous is peptides that arise from within your own biology. Insulin is a peptide. Oxytocin, which you have probably heard called the bonding hormone, is a peptide. Glucagon, which raises blood glucose when it falls too low, is a peptide. The enkephalins, which are endogenous opioid peptides that modulate pain and mood, are peptides. Growth hormone itself is on the larger end of what some classify as peptides. The human body has evolved over millions of years to both produce and respond to peptides, and the receptors and downstream signaling cascades that peptides activate are extraordinarily sophisticated. This is part of why there is so much scientific and medical interest in peptides as potential therapeutic agents. If you can identify a peptide that your body already produces, understand what it does, synthesize it or a variant of it, and deliver it to the right tissue at the right time, you have, in theory, a highly targeted intervention that works through biological mechanisms the body already understands. The appeal is obvious. The complexity, as we will see, is also enormous. There is an important distinction I want to establish early in this conversation, and it is the distinction between endogenous peptides and exogenous synthetic peptides. Endogenous peptides, again, are the ones your body produces. Exogenous synthetic peptides are created in a laboratory, often to mimic or enhance the effects of endogenous peptides, sometimes to activate the same receptor with greater potency or longer duration, and sometimes to create entirely novel signaling effects. When people talk about peptide therapy or peptide supplementation in the biohacking and performance communities, they are almost always talking about exogenous synthetic peptides. And this is where the regulatory landscape becomes critical. In the United States, the FDA classifies most synthetic peptides that are used for their physiological effects as drugs, not as dietary supplements. This means they require clinical trial evidence of safety and efficacy before they can be prescribed for specific indications. Many of the peptides we will discuss today have not completed that regulatory process. Some are classified as research chemicals, which means they are legally sold for laboratory research, but not for human use. Others are approved medications, approved for specific indications, but often used off-label for purposes that are not in the approved label. And some exist in a complex gray area where they are compounded by pharmacies under certain regulatory frameworks. Understanding where a particular peptide sits in this landscape is essential for anyone evaluating the risk-benefit profile of using it. Now I want to talk about the fundamental challenge with peptides from an evidence standpoint, because this shapes everything that follows. The gap between animal data and human data is enormous in the peptide space, and I do not use that word enormous lightly. There are peptides with extraordinary animal data, truly remarkable effects in rodent models and in some in vitro, meaning cell culture studies. Effects on tissue healing, on neuroprotection, on longevity biomarkers, on body composition. And then when you look for rigorous human clinical trial data, you often find very little. Sometimes you find nothing. And the reason for this gap is not necessarily that the compounds do not work in humans. It may be, in some cases, that the animal data genuinely does not translate. Rodent physiology is meaningfully different from human physiology in ways that are relevant to many of these compounds. Rodents have different metabolic rates, different hormonal milieus, different pharmacokinetics, which means the way the body absorbs, distributes, metabolizes, and excretes these compounds is different. A dose that is effective and safe in a rodent may translate to something very different in a human when adjusted for body weight and metabolic rate. There is also the reality that the pharmaceutical industry has limited financial incentive to conduct expensive human clinical trials on compounds that, in some cases, cannot be easily patented, which affects the flow of research funding. And for some of the more esoteric peptides, even academic research interest has been limited. So we are often working from a data set that is genuinely incomplete, and intellectual honesty requires acknowledging that directly. Another critical variable in the peptide conversation is sourcing, and I want to spend real time on this because I think it is underappreciated in popular discussion. The quality of a synthetic peptide depends entirely on the quality of the synthesis and purification process. Peptide synthesis is not trivial. It requires sophisticated chemistry and rigorous quality control. The potential contaminants in a poorly synthesized peptide include residual reagents from the synthesis process, incorrect sequences where amino acids have been added in the wrong order or the wrong amino acid has been incorporated, aggregated peptide structures that may behave differently from the intended monomeric form, and endotoxins, which are bacterial cell wall components that contaminate many products synthesized in less than sterile conditions and that can cause severe inflammatory reactions when injected. When you purchase a peptide from an unregulated source, which describes many of the gray market peptide suppliers that cater to the biohacking community, you have essentially no guarantee of what you are actually getting. The label may say BPC-157 at a concentration of 5 milligrams per vial. What is actually in the vial may be a mixture of the intended compound, synthesis byproducts, impurities, and potentially something else entirely. This is not a hypothetical concern. There are documented cases of serious adverse events from gray market peptides, including from what appear to be contaminants rather than the intended compound. Conversely, peptides sourced from licensed compounding pharmacies operating under state pharmacy board oversight and following USP standards for sterile compounding represent a significantly different risk profile than gray market research. Chemicals. That distinction matters, and we will come back to it for each compound we discuss. The route of administration also matters enormously for peptides, and I want to address this clearly. Most of the peptides we are going to discuss are injected subcutaneously, which means just under the skin or intramuscularly. The reason for this is that peptides are composed of amino acids, which are broken down in the digestive system before they can be absorbed intact. If you swallow a peptide, it is largely digested in the stomach and small intestine. And what you absorb is individual amino acids or small fragments, not the intact peptide with its intended signaling function. There are exceptions to this. BPC-157 is one of the compounds for which there is at least some evidence that an oral form has biological activity, possibly due to local effects in the gastrointestinal tract, and possibly due to some mechanism of partial intact absorption that is not fully understood. But for the majority of peptides, injection is the only route that delivers meaningful circulating concentrations of the intact molecule. And injection carries its own risks independent of the peptide itself, including infection at the injection site, particularly with non-sterile technique or non-sterile peptide preparations and local tissue reactions. These are not reasons to categorically reject injectable peptides for people who have determined with a physician that the risk-benefit profile is acceptable. They are reasons to take the preparation and administration of these compounds extremely seriously. Sponsor break 1 to 2 minutes. Now let us go through the specific compounds. I am going to cover each one with the same structure: what it is, the proposed mechanisms, what the animal data shows, what the human data shows, the regulatory status, the sourcing considerations, and the safety profile as best as we can determine it, BPC. 157 is where I want to start because it is by far the most widely used peptide outside of the approved pharmaceutical context, and it has a genuinely interesting scientific story. BPC stands for Body Protection Compound, and the compound designated BPC-157 is a 15 amino acid sequence that was originally derived from a protein found in gastric juice, the digestive secretions of the stomach. The sequence was identified and studied extensively by a Croatian researcher named Dr. Predrag Sekiric and his colleagues at the University of Zagreb, whose work has produced a remarkable volume of animal research over several decades. Let me be precise about the mechanisms that have been proposed for BPC-157 in animal studies, because the list is genuinely extensive. In rodent models, BPC-157 has been shown to accelerate healing of various tissue types, including muscle, tendon, ligament, bone, and intestinal tissue. The proposed mechanisms include upregulation of growth hormone receptors in tendon tissue, which would make those tissues more responsive to endogenous growth hormone signaling, stimulation of the formation of new blood vessels through a process called angiogenesis, which would improve blood supply to healing tissue, modulation of the nitric oxide system, which affects vascular tone, blood flow, and cellular signaling, anti-inflammatory effects at the level of certain cytokine pathways, neuroprotective effects in models of brain and spinal cord injury, and effects on the dopaminergic system that have produced results in rodent models of depression and anxiety. I want to pause on that list for a moment because it is important to understand something. When a compound appears to have effects on this many different systems, in this many different tissue types, through this many different proposed mechanisms, there are two possible explanations. Either the compound truly has broad systemic effects that operate through some master regulatory mechanism, or alternatively, some of the findings reflect the inherent complexity of rodent physiology and the ways in which biological systems are interconnected such that an intervention in one area produces cascading effects elsewhere. Both explanations may be partially correct, and the challenge is that we do not have the human data to sort out which effects are real and clinically meaningful in people. The human data on BPC-157 is limited. There have been some clinical trials conducted, primarily by Securix Group, but most of these have been small, and the evidence base does not meet the standards that the FDA would require for approval of a drug for most indications. What we do have is a very large informal data set from people who have used BPC-157 and reported their experiences. And the anecdotal reporting in the biohacking and sports medicine communities is actually fairly consistent. People report accelerated recovery from tendon injuries, from muscle tears, and from surgeries. Some report improvements in gastrointestinal symptoms. The consistency of self-reported positive effects is notable, but I want to be careful here. Self-reported outcomes, particularly when the person knows what they are taking and has a prior belief that it will work, are notoriously subject to placebo effect and confirmation bias. This does not mean the reports are meaningless. It means they cannot be interpreted as definitive evidence of efficacy. What is particularly interesting about BPC-157, and what distinguishes it somewhat from many of the other compounds we will discuss, is the evidence for oral bioactivity. Some of the animal research suggests that oral BPC-157 produces measurable effects, particularly in the gastrointestinal system, but also systemically in some models. If this translates to humans, it would make BPC-157 significantly more accessible and would reduce the risks associated with injection. However, the human pharmacokinetic data to confirm this is not yet available in the published literature. From a safety standpoint, BPC-157 has been used in a very large number of people based on the anecdotal evidence, and the reported adverse effect profile is relatively modest. The most commonly reported issues are local reactions at injection sites and occasional nausea. There have been concerns raised about potential effects on tumor growth because angiogenesis, which BPC-157 appears to stimulate, is also a mechanism that tumors exploit to establish blood supply. In animal models, the existing data does not show BPC-157 to be carcinogenic, but long-term safety data in humans simply does not exist. This is an important caveat for anyone considering this compound, particularly for extended use. The regulatory status in the United States is that BPC-157 is not an FDA-approved drug and is not approved for human use. It has been sold as a research chemical and has been available through compounding pharmacies under certain interpretations of compounding regulations. Though the FDA has periodically moved to restrict compounded versions of BPC-157, anyone interested in BPC-157 should consult a physician familiar with this compound and check the current regulatory status, which has been evolving. GHK-Cu is a copper peptide that exists as a natural component of human plasma, saliva, and urine. GHK stands for glycine, histidine, lysine, which are the three amino acids in the peptide, and Cu is the chemical symbol for copper. This compound has been studied for several decades with early work from the biochemist Loren Pickart, who identified the compound and its copper binding properties and has spent much of his career studying its biological effects. The biology of GHK-Cu is genuinely fascinating. At the receptor level, GHK-Cu has been shown in vitro and in animal studies to regulate the expression of a remarkable number of genes, with some analyses suggesting it modulates the activity of over 4,000 genes. The direction of that modulation appears to be broadly restorative, downregulating genes associated with inflammation and upregulating genes associated with tissue repair, antioxidant defense, and cellular maintenance. The primary effects studied include wound healing and skin repair, where GHK-Cu has the most robust evidence base, including some human data, specifically in the context of topical application to skin. It appears to stimulate collagen and elastin synthesis, promote angiogenesis in wound beds, and reduce inflammation. There are also animal studies showing neuroprotective effects, effects on hair growth, and effects on organ protection in models of injury. The human data for GHK-Cu is strongest in the topical application context. There are published human studies showing improvements in skin thickness, wrinkle reduction, and wound healing with topical GHK-Cu preparations. This makes GHK-Cu one of the peptides with the most direct human evidence for at least one of its proposed applications. The systemic use of GHK-Cu through injection is a different matter. Here, the data is primarily from animal studies, and the human data for injected GHK-Cu is quite limited. From a safety perspective, topical GHK-Cu has a very favorable safety profile based on its use in cosmetic products over many years. Systemic injected GHK-Cu has a much less well-characterized safety profile in humans. Copper is an essential trace mineral but is toxic at high concentrations, and the complex interaction of exogenous GHK-Cu with copper homeostasis in the body is not fully understood. As with BPC-157, the regulatory status is that GHK-Cu is not an FDA-approved drug for systemic use, though it exists in numerous topical cosmetic preparations that are widely available. Pinealon and Epithalon are two peptides that I want to discuss together because they come from the same research tradition and target some of the same biological systems. Both were developed by a research group at the St. Petersburg Institute of Biogerontology and Biogenic Stimulators in Russia, associated with the work of Vladimir Kavinson, who has spent decades studying short peptide bioregulators derived from various organs and tissues. This is an important piece of context. A significant proportion of the published research on these peptides comes from this single research group and from Russian scientific literature, which has been less integrated into the international peer-reviewed literature than research from other scientific centers. This does not make the research wrong, but it means it has received less independent replication than would be ideal for compounds that are now being used by people seeking longevity and cognitive benefits. Pinealon is a tripeptide, meaning a 3-amino acid peptide, with the sequence EDR, meaning glutamic acid, aspartic acid, and arginine. It is claimed to be a peptide bioregulator derived from the pineal gland, which, as you may know, is the structure in the brain that produces melatonin and is involved in circadian rhythm regulation. The proposed effects of Pinealon include neuroprotection, improvement in cognitive function, particularly in aged animals or in models of neurological insult, and various anti-aging effects. The animal data from Kavinson's group shows interesting results on lifespan in rodents and on various neurological and cognitive parameters. Independent replication of these findings is limited. Human data is essentially absent from the peer-reviewed literature in a rigorous clinical trial format. Epithalon, also called Epithalon, is a tetrapeptide, meaning a 4-amino acid peptide, with the sequence AEDG. It is claimed to be derived from the epithalamus, which is a region of the brain that includes the pineal gland. The most significant proposed mechanism for epithalon is stimulation of telomerase activity. Telomeres are the protective end caps of chromosomes, sequences of repetitive DNA that shorten with each cell division and with age-related damage. Telomerase is the enzyme that can restore telomere length. The shortening of telomeres over time is one of the biological hallmarks of aging, and the ability to maintain telomere length is theoretically associated with reduced cellular senescence and potentially extended lifespan. The animal data from Kavinson's group on epithalon shows what appear to be significant effects on telomerase activity, on antioxidant parameters, and on lifespan in various rodent models. Some of the reported lifespan effects in fruit fly and rodent models are remarkable, with increases in mean lifespan of 30 to 40% reported in some studies. And this is the part where I want to be particularly careful. A lifespan extension of 30 to 40% in a rodent model of aging is an extraordinary finding. Findings of that magnitude typically attract significant scientific attention and independent replication. The relative absence of that independent replication for Epithalon is something I want to flag directly. It does not mean the findings are fabricated. It may mean they have not yet been widely investigated by other groups. But it means the evidence base is substantially weaker than the enthusiastic reporting about Epithalon in longevity communities might suggest. Human data for Epithalon is extremely limited. There are some small studies from Cavinson's group suggesting effects on melatonin secretion and on various hormonal and immune parameters in elderly subjects, but rigorous randomized controlled trial data in humans does not exist for Epithalon's proposed longevity and cognitive effects. The GLP-1 receptor agonists represent a fundamentally different category from everything we have discussed so far. These are approved pharmaceutical medications with extensive human clinical trial data. The GLP-1 system is one of the most therapeutically important discoveries in metabolic medicine in the past several decades. GLP-1 stands for glucagon-like peptide 1, and it is an endogenous incretin hormone. What I mean by incretin is a gut-derived hormone that is released in response to food consumption and that potentiates insulin secretion from the pancreas in a glucose-dependent manner. So when you eat, your gut releases GLP-1. GLP-1 travels to the pancreas, and it stimulates insulin release in proportion to how high your blood glucose is. But the biology of GLP-1 goes well beyond pancreatic insulin secretion. GLP-1 receptors are expressed in the brain, particularly in the hypothalamus and brainstem regions involved in appetite regulation, in the vagal nerve, in the heart, in the kidneys, in the gastrointestinal tract itself, and in various other tissues. And the effects of GLP-1 signaling in these tissues are remarkably broad. In the brain, GLP-1 receptor activation reduces appetite and food reward. In the stomach, it slows gastric emptying, meaning food moves more slowly from the stomach to the small intestine, which contributes to prolonged satiety. In the heart, GLP-1 signaling appears to have direct cardioprotective effects that are independent of its effects on body weight. And in the liver, it reduces hepatic glucose output and may reduce fat accumulation. The development of synthetic GLP-1 receptor agonists, peptide analogs, that bind and activate the GLP-1 receptor but are modified to resist the rapid degradation that endogenous GLP-1 experiences, has produced what is arguably the most significant pharmacological advance in the treatment of obesity and type 2 diabetes in generations. Semaglutide, sold under the brand names Ozempic for diabetes and Wegovy for obesity, is perhaps the most prominent of these compounds. It is a once-weekly injectable GLP-1 receptor agonist approved by the FDA for type 2 diabetes and for chronic weight management in adults with obesity. The clinical trial data for semaglutide is extensive and genuinely impressive. The SUSTAIN trial series for its use in type 2 diabetes showed significant improvements in glycemic control and notable cardiovascular benefits. The STEP trial series for its use in obesity showed average weight reductions of approximately 15% of body weight, which is substantially greater than any previously approved pharmacological intervention for obesity. The SURMOUNT trial, evaluating tirzepatide, which activates both GLP-1 and GIP receptors, where GIP stands for glucose-dependent insulinotropic polypeptide, showed average weight reductions approaching 20 to 22%. These are not trivial effects. They represent a meaningful shift in what pharmacological treatment of obesity is capable of achieving. Retatrutide, which is a newer compound in clinical development, is a triple agonist that activates GLP-1, GIP, and glucagon receptors simultaneously. Early phase 2 trial data published in the New England Journal of Medicine showed average weight reductions approaching 24% over 48 weeks, which would represent the largest pharmacologically induced weight reduction ever demonstrated in a clinical trial for obesity. The compound is not yet approved and was still in clinical trials as of my knowledge cutoff. The safety profile of the approved GLP-1 receptor agonist is important to understand in detail. The most common adverse effects are gastrointestinal, nausea, vomiting, diarrhea, and constipation, particularly during dose initiation and escalation. These often improve with time. There are more serious but less common concerns that require acknowledgement. There is an FDA boxed warning on semaglutide and related compounds about a potential risk of thyroid cell tumors based on animal data, though the human data has not demonstrated an increased risk of medullary thyroid carcinoma, and the FDA warning is precautionary. There are also reports of acute pancreatitis, and individuals with a personal or family history of pancreatitis or medullary thyroid carcinoma or multiple endocrine neoplasia type 2 should not use these compounds. There's been significant discussion about potential effects on muscle mass since the weight lost on GLP-1. Receptor agonists includes both fat mass and lean mass, with some studies suggesting that a meaningful proportion, potentially 20 to 40% of the weight lost, is lean tissue rather than fat. This is an important consideration, particularly for older adults and for anyone who exercises. The emerging consensus in the field is that adequate protein intake and resistance training during GLP-1 receptor agonist therapy is important to minimize lean mass loss. There have also been emerging reports of gastrointestinal adverse events, including gastroparesis, a serious condition of delayed gastric emptying, in some individuals using GLP-1 receptor agonists, and this requires further investigation. I also want to address something called Ozempic face, which is a popular term for the facial volume loss that some people notice during rapid weight loss on GLP-1 receptor agonists. This is not a specific effect of GLP-1 receptor agonists per se. It is a consequence of rapid weight loss from any cause, which can reduce facial adipose tissue. It is a cosmetic concern rather than a medical one, but it is worth being aware of. The non-pharmaceutical gray market versions of GLP-1 receptor agonists deserve specific attention. The enormous demand for semaglutide and related compounds, combined with shortages of the branded pharmaceutical products and high out-of-pocket costs for patients without insurance coverage, has created a substantial gray market for compounded and counterfeit versions of these products. This is a serious safety concern. The FDA has issued multiple warnings about counterfeit semaglutide products that have caused adverse events, including hospitalizations. Compounded versions of semaglutide have been legally available from certain compounding pharmacies under FDA policies related to drug shortage, but this landscape has been evolving rapidly. Anyone considering a GLP-1 receptor agonist should obtain it through legitimate pharmaceutical channels with a prescription from a licensed healthcare provider who can appropriately evaluate whether the compound is indicated and monitor for adverse effects. Sponsor break, 2 to 2 minutes. Melanotan and its derivatives are the next category I want to address, and I want to be particularly direct about this one because I think it is important. Melanotan I and Melanotan II are synthetic peptide analogs of alpha-melanocyte stimulating hormone, which is abbreviated as alpha-MSH. Alpha-MSH is an endogenous peptide that binds to melanocortin receptors, particularly the MC1 receptor on melanocytes, the cells that produce melanin pigment in the skin, and stimulates melanin synthesis. The original scientific motivation for developing melanotan was the idea that a compound that could stimulate tanning without UV radiation might protect against skin cancer by increasing the skin's natural UV defense mechanism. The early research was conducted at the University of Arizona beginning in the late 1980s and 1990s, primarily by Norman Levine and Mac Hadley. Melanotan I, which is also known by the pharmaceutical name afamelanotide, has actually completed clinical development and is approved in Europe and Australia as SCENESSE for erythropoietic protoporphyria, which is a rare genetic disorder in which a deficiency of an enzyme leads to accumulation of protoporphyrin in red blood cells and extreme photosensitivity. In that specific approved context, afamelanotide is a legitimate and appropriate medication. Melanotan II is a different story. It is not approved anywhere for human use. It was developed as a research compound and never made it through clinical development, in part because of its side effect profile. Melanotan II binds not just to the MC1 receptor, but also to the MC3 and MC4 receptors. MC4 receptor activation in the brain produces effects on appetite suppression, on erectile function, and on female sexual arousal. This is why Melanotan II became popular in certain communities as both a tanning agent and a sexual function enhancer. A derivative called PT-141, also known as bremelanotide, was actually developed from Melanotan II specifically for its MC4-mediated effects and was approved by the FDA in 2019 for hypoactive sexual desire disorder in premenopausal women under the brand name Vyleesi. The safety profile of Melanotan II, used outside of a clinical context through gray market sources, is a serious concern. The side effects reported with Melanotan II include significant nausea, often severe enough to be debilitating, facial flushing, spontaneous erections in males that can be unwanted and prolonged, and autonomic nervous system effects, including elevated blood pressure. There are also concerning reports of Melanotan II causing the activation of pre-existing moles and nevi, which are pigmented skin lesions, with documented cases of melanoma developing at the site of activated moles in people using Melanotan II. The FDA has never approved Melanotan II for any indication and has issued warnings about it. The gray market versions of Melanotan II present all the sourcing risks I described earlier, with the additional complication that the compound itself has a more significant intrinsic risk profile than some of the other peptides we have discussed. I would be doing a disservice to anyone listening if I did not state this clearly. The risk-benefit calculation for gray market Melanotan II is, in my assessment, based on the available evidence, not favorable for most people. If someone is interested in addressing sexual dysfunction, PT-141 or bremelanotide is an FDA-approved option that should be discussed with a physician. If someone is interested in tanning, the evidence that UV-mediated tanning in the context of a healthy melanin response actually requires UV exposure, and the risks of UV exposure are substantially lower than the risks of unregulated Melanotan II. Now let us talk about the growth hormone-related peptides, which represent one of the most scientifically interesting and one of the most heavily used categories in the performance and longevity space. To understand these peptides, you need to understand the growth hormone axis. Growth hormone is a polypeptide hormone secreted by the anterior pituitary gland. Its release is regulated by two hypothalamic hormones that act in opposition to each other. Growth hormone, releasing hormone, abbreviated GHRH, stimulates GH release. And somatostatin, also called growth hormone inhibiting hormone, suppresses GH release. Growth hormone itself does not produce all of its effects directly. Much of what we attribute to growth hormone, including its effects on muscle protein synthesis, fat metabolism, and tissue repair, is mediated by insulin-like growth factor 1, abbreviated IGF-1, which is produced by the liver and other tissues in response to growth hormone stimulation. As people age, growth hormone secretion declines substantially. Peak growth hormone secretion occurs in adolescence during the pubertal growth spurt, and by middle age, most people are secreting significantly less growth hormone than they did in their 20s. This age-related decline in the growth hormone and IGF-1 axis has been linked to changes in body composition, including reduction in lean mass and increase in fat mass, reduction in bone density, and changes in energy levels in recovery. This observation has motivated decades of interest in growth hormone as an anti-aging and performance-enhancing intervention. Direct growth hormone administration is itself a peptide intervention, since growth hormone is a protein hormone, and it has been used in clinical medicine for decades for FDA-approved indications, including growth hormone deficiency in children and adults, short stature associated with certain genetic conditions, and wasting syndromes associated with AIDS. The off-label use of growth hormone in otherwise healthy adults for anti-aging or performance purposes is controversial, expensive, and carries meaningful risks. The evidence that supraphysiological growth hormone administration in healthy adults produces the hoped-for benefits in body composition and performance is actually weaker than many people believe, while the risks, including insulin resistance, edema, carpal tunnel syndrome, and possible increased risk of certain malignancies are real. The growth hormone secretagogues represent a different approach. Rather than administering exogenous growth hormone directly, these compounds stimulate the pituitary to release more of its own endogenous growth hormone. The theory is that this approach is more physiological, more subject to normal feedback regulation, and therefore safer, while still producing meaningful increases in growth hormone levels. The main categories are the GHRH analogs, which mimic the action of endogenous GHRH, and the growth hormone releasing peptides, or GHRPs, also called ghrelin mimetics, which act through a different receptor called the ghrelin receptor, or growth hormone secretagogue receptor. Sermorelin is a GHRH analog consisting of the first 29 amino acids of endogenous GHRH. It was actually FDA approved for the diagnosis and treatment of growth hormone deficiency and for growth hormone deficiency in HIV, AIDS-associated wasting, though its approval has been through various regulatory changes. Sermorelin is typically administered by subcutaneous injection and produces a pulse of growth hormone release within minutes of administration. Because it works through the normal feedback system, the growth hormone release it produces is subject to regulation by somatostatin, which is theoretically safer than direct growth hormone administration, which bypasses this regulation. CJC-1295 is a GHRH analog that has been modified to have a much longer half-life than natural GHRH or sermorelin, achieved through modification of the peptide to allow it to bind to albumin in the blood, which protects it from rapid degradation. CJC-1295 produces a more sustained elevation in growth hormone compared to the pulsatile release that sermorelin produces. There are two forms of CJC-1295 that differ in this albumin binding property, and the distinction between them is important but often confused in popular discussion. Ipamorelin is a selective growth hormone secretagogue from the GHRP family. What makes ipamorelin notable is its specificity. It is highly selective for the growth hormone secretagogue receptor and does not significantly stimulate cortisol release or prolactin release, which are side effects associated with some other GHRPs. It is often combined with CJC-1295 in clinical practice because the two compounds work through different receptors and have synergistic effects on growth hormone release. MK-677, also called ibutamorin, is an orally active growth hormone secretagogue. This is notable because unlike most peptides, MK-677 is orally bioavailable, meaning it can be taken by mouth and absorbed intact. It is actually a non-peptide molecule that mimics the action of ghrelin at the growth hormone secretagogue receptor. It produces sustained elevation of growth hormone and IGF-1 levels. Clinical trial data on MK-677 has shown effects on body composition, bone density in older adults, and muscle mass in various populations. However, it also stimulates appetite significantly through its ghrelin receptor activity, and it can cause insulin resistance and elevated fasting blood glucose, which is a meaningful concern for people with diabetes risk or metabolic syndrome. Water retention is also commonly reported. From a safety standpoint across the growth hormone secretagogue class, the evidence suggests that using these compounds to bring growth hormone levels from clearly deficient back toward the lower end of the normal physiological range for young adults carries lower risk than attempting to push growth hormone. And IGF-1 levels well above normal ranges. The risks that are most relevant are effects on insulin sensitivity and blood glucose, potential stimulation of any pre-existing malignant cells, since IGF-1 is a growth factor, and growth factors can stimulate tumor growth, and the long-term effects of sustained supraphysiological IGF-1 levels, which are not well characterized in the human literature. The regulatory status varies by compound. Sermorelin has had FDA approval for specific indications. CJC-1295 and ipamorelin are not FDA approved, but have been available through compounding pharmacies. MK-677 is not FDA approved for any indication and is technically a controlled investigational compound in the United States, though it is widely sold in various markets. I want to now address some of the practical frameworks that I think are relevant for anyone listening to this who is considering any of these compounds. The first framework is the hierarchy of evidence. When evaluating any peptide or indeed any health intervention, the quality of the evidence matters enormously. At the top of the hierarchy are large, randomized, placebo-controlled clinical trials in humans, ideally replicated by independent research groups. Below that are smaller clinical trials, then observational human studies, then animal studies, then in vitro cell culture studies. The peptides we have discussed today span almost this entire hierarchy. The GLP-1 receptor agonists sit at the top with abundant high-quality human trial data. BPC-157 sits much lower with primarily animal data. Epithalon and Pinealon are primarily supported by animal data and limited human studies from a single research group. Understanding where a given compound sits in this hierarchy is essential for calibrating how much confidence to have in claims about its effects. The second framework is the distinction between mechanism and outcome. Just because a compound activates a pathway that sounds beneficial does not mean the clinical outcome is beneficial. Biology is extraordinarily complex and redundant. Activating telomerase sounds good if we frame telomere shortening as universally bad, but telomerase activation in inappropriate contexts is also a mechanism used by cancer cells to achieve replicative immortality. The relationship between telomere biology and aging and health is complex, and a compound that stimulates telomerase is not automatically a longevity intervention. Similarly, stimulating angiogenesis sounds good for wound healing, but angiogenesis is also what allows tumors to establish blood supply. The simplistic mapping of mechanism to outcome that characterizes much of the popular discussion around peptides is genuinely dangerous. The third framework is the risk-benefit calculation, and this is personal and context-dependent. A person with a specific documented medical need, diagnosed and treated by a physician, using a compound that has human safety data and is obtained from a legitimate pharmaceutical source, faces a very different risk-benefit calculation than a healthy 25-year-old who reads enthusiastic online accounts, purchases gray market peptides of unknown quality, and self-administers them without medical supervision. The same compound can be a reasonable medical intervention in one context and a poor risk-benefit decision in another. And the absence of serious adverse events in the short term does not constitute safety data. The long-term effects of most of the compounds we have discussed are simply unknown in humans. Let me close with a practical framework for anyone who has concluded after doing the work to understand the evidence that they want to explore peptide therapy. First, identify a physician who is knowledgeable about this area. This is challenging because mainstream medical education has limited coverage of peptide therapeutics, but there are physicians who specialize in longevity medicine, functional medicine, and sports medicine who are familiar with these compounds. Seek out someone who will engage seriously with the evidence rather than someone who simply sells peptide protocols without meaningful medical evaluation. Second, undergo a thorough baseline assessment. Before using any compound that affects growth hormone, body composition, or metabolic parameters, you want baseline measurements of IGF-1, blood glucose, and insulin sensitivity, a comprehensive metabolic panel, and any other parameters relevant to the specific compound. Third, obtain any compounds you use through legitimate, regulated channels to the greatest extent possible. Compounding pharmacies operating under state pharmacy board oversight and following USP sterile compounding standards are a fundamentally different risk profile than gray market research chemical suppliers. Fourth, if you use any of these compounds, do so with regular medical monitoring. The people who use peptides most intelligently use them as part of a monitored protocol with regular laboratory assessment, not as unmonitored self-experiments. Fifth, be honest with yourself about what the evidence actually shows versus what enthusiastic online communities claim. The gap between those two things is often very large in the peptide space. And sixth, remember that the foundational elements of health, sleep, stress management, nutrition, exercise, and meaningful social connection have the most robust and extensive evidence base of any interventions available to us. Peptides, even in the best case, operate at the margin. They are not a substitute for getting the fundamentals right. The key takeaways from today's episode: peptides are signaling molecules composed of short chains of amino acids. Your body produces many of them endogenously. Synthetic exogenous peptides vary enormously in their evidence base, from FDA-approved medications with extensive human trial data to research chemicals with almost no human data. The gap between animal data and human data is one of the defining features of the peptide landscape, and it requires genuine intellectual humility to navigate. BPC-157 has interesting animal data suggesting tissue repair benefits, limited human data, and a currently evolving regulatory status. GHK-Cu has its strongest evidence base in the topical application context with some human data for skin effects. Pinealon and Epithalon have intriguing animal data from a specific research group, but very limited independent replication and essentially no rigorous human clinical trial data. The GLP-1 receptor agonists, including semaglutide and tirzepatide, are FDA-approved medications with extensive human trial data and meaningful efficacy for obesity and type 2 diabetes treatment, with a real but manageable side effect profile when used under medical supervision. Gray market versions of these compounds present serious safety risks. Melanotan II is not FDA-approved, carries significant intrinsic risks, and the gray market versions present the full spectrum of sourcing and contamination concerns. PT-141 is an FDA-approved option for specific indications. The growth hormone secretagogues offer a more physiological approach to growth hormone axis support than direct growth hormone injection, but carry risks related to insulin sensitivity and long-term IGF-1 elevation. And regulatory status varies by compound. Sourcing is one of the most critical variables in the real-world safety of any of these compounds, and there is an enormous quality difference between pharmaceutically regulated sources and gray market research chemical suppliers. And finally, the evidence base for peptides should be evaluated with the same rigor you would apply to any other health intervention, not with the credulous enthusiasm that characterizes much of the online discourse in this space. All referenced studies and researchers are linked in the description below. If you found today's content valuable, please subscribe to the channel and to the podcast, and please share this episode with anyone who is actively considering or currently using peptides without a solid understanding of the evidence. Thank you for your time. And as always, thank you for your interest in science. There is one more area I want to address before we close, which is the question of what responsible use of peptides actually looks like when someone has made an informed decision to explore them with appropriate medical oversight. And I want to go compound by compound here in a way that gives you a practical picture of how a thoughtful clinician might approach each of these. For BPC-157, the most common clinical approach I have seen from physicians who work in this space involves using it for a defined injury recovery period, typically 8 to 12 weeks, at doses that have been used in animal research and that appear to be well tolerated anecdotally in human use, typically in the range of 250 to 500 micrograms per day administered subcutaneously. Some clinicians have begun offering oral BPC-157 preparations based on the limited evidence for oral bioactivity, particularly for gastrointestinal applications. The important points are that baseline labs should be obtained before starting, that use should be time-limited rather than indefinite, and that anyone with a history of cancer or with known tumor burden should not use BPC-157 due to the theoretical concern about angiogenesis stimulation. The evidence base does not tell us what the safe duration of use is because long-term safety data in humans does not exist. This is a meaningful unknown that anyone using BPC-157 should fully appreciate. For the GLP-1 receptor agonists, the clinical approach is substantially more standardized because these are approved medications with established protocols. The standard approach involves beginning at a low dose, typically 0.25 milligrams per week for semaglutide, and escalating gradually over a period of months to minimize gastrointestinal side effects while reaching a therapeutically effective dose. Blood glucose monitoring is important, particularly in people who are diabetic or pre-diabetic, because the glucose lowering effects can be significant. Monitoring for thyroid nodules is recommended given the boxed warning about thyroid cell effects. And as I mentioned earlier, adequate protein intake and resistance training are important throughout the treatment period to minimize lean mass loss. The treatment duration question for these medications is something the field is actively grappling with. Data suggests that stopping GLP-1 receptor agonist therapy results in weight regain in the majority of patients, raising questions about whether these medications need to be taken indefinitely for weight management, which is not dissimilar to the situation with other chronic disease medications. This is an active area of clinical research, and guidelines are evolving. For the growth hormone secretagogues, the clinicians I am aware of who use these most thoughtfully do so by first establishing whether the patient has evidence of actual growth hormone axis dysfunction, not just age-related decline, because the risk-benefit calculation is different for someone with documented deficiency versus someone who simply wants to optimize performance. IGF-1 is the most practical biomarker here, as it reflects integrated growth hormone secretion over 24 hours, better than spot growth hormone measurements, which fluctuate enormously throughout the day. A low normal IGF-1 in a middle-aged or older adult may reflect the age-related decline in growth hormone secretion, and returning those levels to the upper half of the normal physiological range through a growth hormone secretagogue is a different intervention than pushing IGF-1 to supraphysiological levels. The distinction matters for both efficacy and safety. Regular IGF-1 monitoring during growth hormone secretagogue therapy is important, as is monitoring of fasting, blood glucose, and insulin, given the effects of IGF-1 on insulin sensitivity. And the cautionary note about IGF-1 and cancer risk deserves to be taken seriously rather than dismissed. The epidemiological data on IGF-1 levels and cancer risk shows a correlation between higher IGF-1 levels and increased risk of certain cancers, including prostate, breast, and colorectal cancer, though the relationship is complex and the magnitude of risk associated with levels within the physiological range rather than supraphysiological levels is debated. Anyone with a personal or family history of hormone-sensitive cancer should discuss this specifically with their physician before considering growth hormone secretagogue therapy. I also want to say something about the psychological dimension of peptide use that I think does not get discussed enough. There is a subset of people who are drawn to peptides and biohacking interventions more broadly by a kind of optimization anxiety, a state where the pursuit of every possible performance or health edge becomes its own source of stress and preoccupation. The irony, of course, is that chronic psychological stress has measurable negative effects on the very biological systems that peptides are often used to optimize through effects on cortisol, on inflammatory signaling, on sleep quality, and on many other pathways. If using peptides requires constant monitoring, sourcing anxiety, concern about regulatory changes, and uncertainty about what you are actually injecting yourself with, those psychological costs are real and should be weighed against whatever benefits are hoped for. The people I observe using these tools most sensibly tend to be those who have genuinely solid fundamentals, who sleep well, who manage stress effectively, who train appropriately and eat well, and who approach peptides as a marginal addition to an already strong foundation rather than as a primary intervention. That is a useful frame for anyone evaluating this space. The emerging frontier in peptides is worth at least a brief discussion because the field is moving quickly. Several areas are particularly active. First, there is significant research on oral delivery of peptides that would traditionally require injection, using various formulation technologies to protect peptides from gastrointestinal degradation and improve absorption. If this technology matures and delivers on its promise, it will substantially change the risk profile of many peptide interventions by eliminating the injection requirement. Second, there is growing interest in tissue-selective peptides and peptide conjugates that can be targeted to specific organs or cell types, reducing systemic exposure and side effects. Third, the longevity research space is increasingly intersecting with peptide research, with investigators examining compounds like humanin and MOTS, which are mitochondria-derived peptides that appear to have systemic effects on metabolic health and stress resistance. These are still early stage, but represent a fascinating direction. Fourth, the convergence of artificial intelligence-driven protein structure prediction and peptide design is creating the possibility of designing entirely novel peptides with specific target activities at a pace that would have been impossible even 5 years ago. This is both exciting and concerning from a safety standpoint because the timeline from computational design to human experimentation in some parts of the gray market is much shorter than the timeline through formal regulatory processes. My overall assessment of the peptide space, which I want to offer not as a definitive verdict, but as my honest synthesis of the available evidence, is this. It is a field with genuine scientific promise, meaningful existing evidence in specific areas, particularly the GLP-1 receptor agonists, and a significant body of interesting but preliminary data for other compounds. It is also a field that is characterized by a concerning gap between the enthusiasm of the user community and the rigor of the underlying evidence, by a sourcing landscape with serious quality and safety concerns in the gray market, and by genuine unknowns about long-term safety that no amount of enthusiastic anecdotal reporting can substitute for. The people who will benefit from this field are those who engage with it with clear eyes, appropriate medical supervision, realistic expectations about what the evidence supports, and a genuine commitment to getting the foundational health behaviors right first. If there is one thing I hope you take from today's episode, it is this. Understand the hierarchy of evidence for any compound you are considering. Understand where that compound sits in the regulatory landscape. Understand the sourcing risks and have a physician involved who will actually monitor what is happening in your body over time. That framework does not guarantee good outcomes, but it is the closest thing to responsible engagement with a complex and evolving space that the current state of the science allows. The research is moving quickly, and I expect our understanding of many of these compounds to change meaningfully over the next several years. Stay curious, stay rigorous, and stay honest about what we know and what we do not. Let me now address some of the specific questions and misconceptions that come up most frequently in the peptide community, because I think addressing them directly will be useful for anyone listening who is actively navigating this space. One of the most common questions I hear is whether peptides are detectable on drug tests. This is relevant for competitive athletes and for anyone subject to workplace drug testing. The answer varies significantly by compound. The World Anti-Doping Agency, WADA, maintains a prohibited list that includes growth hormone and IGF-1, along with specific growth hormone releasing factors and peptide hormones. WADA has been progressively expanding its detection capabilities for peptides, and the prohibited list includes GHRPs and GHRH analogs as prohibited substances in competitive sport. Semaglutide and other GLP-1 receptor agonists were not on the WADA prohibited list as of my last update, though this is something competitive athletes should verify with their sport governing body. For workplace drug testing, the standard panels used in most occupational drug screening do not test for peptides, but this is context dependent and should be verified for any specific testing program. More broadly, if you are a competitive athlete subject to anti-doping rules, you should consult with a WADA-accredited expert before using any peptide, approved or otherwise. Another common question concerns stacking, which is the practice of using multiple peptides simultaneously. The rationale typically offered for stacking is that different peptides work through different mechanisms and may therefore produce additive or synergistic effects. CJC-1295 plus ipamorelin is one of the most commonly discussed stacks because CJC-1295 works through the GHRH receptor and ipamorelin works through the ghrelin receptor. And the two receptors have different but complementary roles in growth hormone release. The scientific rationale for combining them is reasonably sound, and this combination is one that some physicians use in clinical practice. What I want to be very direct about is that when you combine multiple compounds with unknown long-term safety profiles, the complexity of potential interactions increases substantially. Two compounds that are individually tolerable may interact in ways that neither animal nor human data can predict with confidence, particularly when both are obtained from gray market sources with uncertain purity. Stacking multiple research chemicals is a significant escalation of risk relative to using a single compound under medical supervision, and the enthusiasm with which stacking protocols are discussed in online communities is not matched by any meaningful safety data. The question of cycling, meaning using peptides for a defined period followed by a break, also comes up frequently. The rationale for cycling is twofold. First, some peptides may produce receptor downregulation over time, meaning that continuous use reduces the sensitivity of the target receptor and the compound becomes less effective. Second, cycling allows the user to assess their baseline state periodically and provides natural breaks in exposure that might reduce long-term risk. For the growth hormone secretagogues, there is some theoretical basis for cycling based on what we know about receptor pharmacology, though the clinical significance of growth hormone secretagogue receptor desensitization with continuous use is debated. For GLP-1 receptor agonists, the approved medications are intended for continuous use in the clinical context since the evidence shows weight regain upon discontinuation. For BPC-157 and similar compounds, the typical clinical approach involves time-limited use for a specific indication rather than indefinite use, which functionally represents a form of cycling. The honest answer is that we do not have the long-term human data to know whether cycling offers meaningful safety benefits for any of these compounds. It is a reasonable precautionary approach, but it should not be mistaken for a risk elimination strategy. There is also the question of who should categorically not be using peptides, and I want to be very clear about this. Pregnant or breastfeeding women should not use any of these compounds as the effects on fetal development and infant health are unknown. People with active cancer or a history of cancer should be particularly cautious about any compound that stimulates growth factor pathways or angiogenesis, which includes the growth hormone secretagogues, BPC-157, and GHK-Cu, and should only consider any such compound with explicit guidance from their oncologist. People with thyroid cell tumors or a personal or family history of multiple endocrine neoplasia type 2 should not use GLP-1 receptor agonists. People with active psychiatric conditions, particularly those taking medications that affect dopaminergic or serotonergic signaling, should be cautious about compounds that affect those systems. And people who are immunocompromised, whether from medication or from disease, have heightened risk from any injectable compound due to infection risk, and should only use injectables in the context of close medical supervision. I want to return to something I said earlier in this episode about the broader context in which peptide use happens, because I think it is genuinely important. The most powerful interventions available to us for health and longevity do not require a prescription, a needle, or a credit card transaction with a gray market supplier. Sleep duration and quality, physical activity, and specifically resistance training combined with cardiovascular training, nutrition with adequate protein and micronutrients, social connection, stress management, and the avoidance of cigarette smoking and excessive alcohol are each individually associated with enormous reductions in all-cause mortality and in the risk of essentially every major chronic disease. The effect sizes of these behavioral interventions on health outcomes dwarf the effect sizes of any peptide we have discussed today in human data. This is not an argument against peptides for people who have established the foundational behaviors and who are exploring additional interventions in a responsible way. It is an argument for appropriate prioritization. If your sleep is poor, if you are not exercising regularly, if your diet is significantly caloric surplus or nutritionally deficient, if you are smoking or drinking heavily, no peptide protocol will meaningfully offset those deficits. The biology is clear on this. There is something that I think is worth naming directly, which is the role of the placebo effect in the peptide community. The placebo effect is one of the most robust and reproducible phenomena in all of medicine. When a person believes they have received an effective intervention, they often experience measurable improvements in subjective outcomes like pain, energy, mood, and performance, even when the intervention is inert. In the context of peptides, where the user has typically done significant research, has strong prior beliefs about efficacy, is aware of what they are taking, and often pays a significant amount of money for the compounds, the conditions for a robust placebo response are essentially perfect. I am not saying that the improvements people report from peptides are entirely or even primarily placebo. Some of them may reflect real pharmacological effects. But the inability to distinguish genuine pharmacological effects from placebo effects in the absence of blinded controlled trials is precisely why those trials are necessary and why their absence in the peptide space is such a significant limitation. This is not unique to peptides. It applies to a large proportion of the supplements and interventions in the health optimization space, but it deserves explicit acknowledgement whenever the evidence base is largely self-reported outcomes from people who know what they are taking. Let me also address the economic dimension of peptide use because it is relevant to understanding the landscape. The gray market peptide industry is substantial. Some estimates put the market for research peptides at hundreds of millions of dollars annually. The people selling these compounds have obvious financial incentives to present the evidence in the most favorable possible light. The influencers and content creators in the biohacking space who discuss peptides often have financial relationships with suppliers, whether through direct sponsorship, affiliate relationships, or other arrangements that create conflicts of interest. I am not suggesting that everyone who advocates for peptides is acting in bad faith. Many of them are genuinely enthusiastic about the science and their own subjective experiences. But the financial architecture of this industry means that you should apply particular scrutiny to sources of information that also happen to be selling you something or directing you towards someone. Academic researchers studying these compounds have their own incentive structures, including publication pressure and grant funding dynamics, but they operate within a peer review system that provides at least some check on the most egregious overclaiming. That system is largely absent in the gray market peptide space. For those who want to stay current on the evolving science in this area, I would recommend following the primary literature directly rather than relying exclusively on secondary sources. PubMed is freely accessible and allows you to search for any of the compounds we discussed and see what the peer-reviewed literature actually says. The key question to ask when reading any study is not just whether the results were positive, but what the study design was, what population was studied, whether the study was adequately powered, who funded it, and whether it has been independently replicated. These are basic critical appraisal skills that are enormously valuable for navigating the peptide space and health information more broadly. I also recommend following the work of researchers who study these compounds and who communicate with appropriate uncertainty rather than those who make strong categorical claims. Science at the frontier is characterized by uncertainty, and anyone who speaks about these compounds with total confidence in either direction is probably not engaging with the full complexity of the evidence. As a final note before the closing summary, I want to acknowledge something about my own position here. I have received a great deal of interest from members of this community in whether I personally use any of these compounds. I want to be thoughtful about this because I think the parasocial dynamics of media create situations where disclosure of personal use by a person with a public platform can function as an implicit endorsement even when that is not the intent. What I can say is that I take seriously the evidence for sleep, exercise, nutrition, and stress management as the primary levers of health, and that I approach the question of any additional intervention with the same framework I have described for you today, which means being genuinely rigorous about what the evidence shows, being realistic about the unknowns, and being conservative in proportion to the uncertainty. Let me now bring together the key takeaways from today's comprehensive review of peptides. Peptides are short chains of amino acids that function as signaling molecules. Your body produces hundreds of them endogenously. The synthetic peptides used in the performance and longevity communities vary enormously in their evidence base, regulatory status, and safety profile. BPC-157 has a significant body of animal research suggesting tissue repair and healing effects through multiple mechanisms, limited but growing human data, and an evolving regulatory landscape in the United States. It appears relatively well tolerated based on anecdotal human use, but has no long-term human safety data. GHK-Cu has its strongest evidence in topical application for skin repair and wound healing, with some human data in that context. Systemic injected GHK-Cu has limited human data and theoretical concerns about copper homeostasis at high doses. Pinealon and Epithalon have interesting animal data from a primarily Russian research tradition with limited independent replication and essentially no rigorous human clinical trial data. The claims about epithalon and telomerase-mediated longevity are scientifically plausible in mechanism, but not yet supported by human evidence. The GLP-1 receptor agonists, including semaglutide and tirzepatide, are FDA-approved medications with the most robust human evidence base of any class we discussed, producing meaningful and clinically significant weight reduction and metabolic improvements. They carry real side effects that require medical management and ongoing monitoring. Gray market versions carry serious safety risks. Melanotan II is not FDA-approved, carries meaningful intrinsic risks, including activation of pigmented lesions, and the gray market versions compound those risks with sourcing and contamination concerns. PT-141 is the FDA-approved option for sexual dysfunction indications. The growth hormone secretagogues, including sermorelin, CJC-1295, ipamorelin, and MK-677, represent a more physiological approach to growth hormone axis support than direct growth hormone administration, with a risk profile that depends heavily on dosing intent and baseline IGF-1 status. IGF-1 monitoring, glucose monitoring, and awareness of theoretical cancer growth promotion risks are important. Sourcing quality is one of the most critical and most underappreciated variables in real-world peptide safety. Compounding pharmacies operating under regulatory oversight represent a fundamentally different risk profile than gray market research chemical suppliers. The evidence hierarchy should guide your confidence level. Abundant human clinical trial data justifies much greater confidence than animal data alone. The gap between the two is where most of the peptides outside the GLP-1 class currently sit. Foundational health behaviors, including sleep, exercise, nutrition, and stress management, have larger effect sizes on health outcomes than any peptide intervention in the current human evidence base and should be prioritized accordingly. All of the studies, researchers, and compounds discussed today are linked in the description below. If you found this episode valuable, please share it with someone who is actively navigating the peptide space, because having a clear-eyed understanding of what the evidence actually shows is the most useful thing you can bring to decisions in this area. Subscribe to the podcast on your preferred platform. And if you have questions or topics you would like me to address in future episodes, those are in the community tab. Thank you for your time, for your intellectual engagement with difficult and nuanced material. And as always, thank you for your interest in science.